Hola, hola, muy buenos días a todos. Muchas gracias por estar aquí, daros la bienvenida en primer lugar. Yo creo que este es uno de los momentos en donde los congresos se congratulan de tener simposium como este. Es un simposio muy especial porque tenemos con nosotros a dos speakers que son los investigadores principales de dos estudios pivotales que han cambiado nuestra manera de entender el abordaje de la enfermedad renal crónica, tanto en el ámbito de la diabetes como en el paciente no diabético. Es un lujo tener aquí a Guido Lambers-Herspink y a William Harrington. Así que la recomendación es disfrutar de las charlas y, por favor, con estos dos personajes, cualquier cuestión, no os quedéis con la duda, porque no vais a tener muchas oportunidades de directamente poder preguntarlas. Pepa.
I'm very pleased to introduce today the two speakers. I think that they are friends, and this is a shame because I was thinking that today we can place them together in a fight. What should we use, EMPA-glyphosate or dapagliflozin? So maybe we can try. And the first speaker is from Oxford. He's really known for all of you, so I will not say all of his achievements. He's a trialist. And he's the leader of the EMPA-KIDNEY, and he will explain us EMPA-KIDNEY, what's new and what's different, and update, because you know last week was the renal week, and I think that let's see if they fight or they keep being friends. The floor is yours.
So, thank you very much for the introduction and enormous thanks for the invitation to present to you all and to travel to Mallorca. So, I'm Will Harrington, I'm a nephrologist, I'm also a trialist, and I lead the renal studies group at the University of Oxford. And I was invited to describe what's new and what's different about EMPA-KIDNEY. So these are my disclosures. EMPA-KIDNEY was initiated, designed, reported by a steering committee led by the University of Oxford, with international experts, but it was funded and sponsored by Boehringer Ingelheim. And it was actually initiated by our group back in 2016 on seeing the results of the EMPA-REG outcome renal analyses. And it took many years to get the trial registered, completed, and it actually was the 13th of the large double-blind placebo-controlled SGLT2 inhibitor trials to report. But it remains relevant because of its design. It was designed with a population-based approach, which meant it included a broad range of patients with chronic kidney disease. And we really wanted to assess, in that broad population with at least a third with and without diabetes, the effects of an SGLT2 inhibitor on renal disease progression. And we aimed to recruit at least 6,000 people. And we wanted a simple set of criteria to identify risk, and we used these. A historical and baseline EGFR between 20 and 45, or between 45 and 90, with some evidence of albuminuria. And the only excluded primary kidney diagnosis was polycystic kidney disease. And participants were randomized in a simple design, which I'm sure you're familiar with, 1-to-1 to empagliflozin versus matching placebo. They had to be on investigator-judged, clinically appropriate RAS inhibition where it was indicated and tolerated, but we had about 15% that weren't treated with a RAS inhibitor. And it was event-driven, and the primary composite was cardiovascular death combined with kidney disease progression, which itself was clinically defined as the need to start maintenance dialysis or receive a kidney transplant, or death from untreated kidney failure. Or it had EGFR-based components, sustained EGFR to less than 10, or a 40% decline from the randomization value. And here are the baseline characteristics you're familiar with, and just as a reminder of what's different about this trial, well, I know this symposium is a little bit about diabetes treatments, but in actual fact, the majority of patients, over 50%, didn't have diabetes, and in fact, nearly 70% had a non-diabetic cause of kidney disease. So many of the patients with diabetes had non-diabetic causes of kidney disease. They were being recruited, as you know, from nephrology clinics. They also had, and nearly half of them had, the low levels of albuminuria, A1 to A2 levels, and it was the lowest of the trials in terms of levels of kidney function represented, with an average eGFR, a mean of 37, and just over a third with an eGFR less than 30. And these were reported last year. The main results of the trial, a 28% reduction in the risk of the primary composite outcome. A clear result. The trial was stopped early. This was at a median of 2 years of follow-up. And there were 990 primary outcomes. We were aiming for 1,070. And of those 990 outcomes, 888 were kidney disease progression, with a lower than expected cardiovascular death event rate, and a point estimate that's consistent with the overall results from the other trials, but not significant statistically if you take it as a nominal p-value. But if you want to put together the clinically most important outcomes in the primary outcomes, so the need to start dialysis or receive a kidney transplant, or death from cardiovascular causes, then you can see there's a clear 27% reduction in risk for those hard clinical outcomes. And we reported last year this subgroup analysis. There were 3 key subgroups that we pre-specified as being most important for emphasis, and this was the first, the diabetes subgroup, and you can see large numbers of events both in people with and without diabetes, and the overall relative risk here is the best estimate of the treatment effect in this analysis, because the heterogeneity p-value, that statistical test for a difference, is non-significant. And this result surprised me and still surprises me. This was the analysis by eGFR, and we can see that we had the largest number of outcomes in the eGFR less than 30 group, as you would expect, because they were already progressing, they're at higher risk, but also because it doesn't take as long to get a 40% decline in your eGFR in that subgroup. But you can see that on this analysis, there was no evidence of the beginnings of a lower threshold below which these drugs stop being effective at modifying risk. And in fact, we've been able to look further in some more recent analyses. These are post-hoc analyses, looking at the 254 patients at randomization who had an eGFR between 15 and 20. Some patients had progressed over the run-in period of 15 weeks and had a lower eGFR. And although we don't have clear results in this subgroup, we still don't start to see the beginnings of a threshold. So despite the fact these drugs have less effect on glycosuria at the lower levels of eGFR and perhaps become very inefficient anti-diabetic treatments, they're still indicated for treatment of risk. And so it's almost never too late, in my opinion, to start an SGLT2 inhibitor. The day before dialysis isn't going to obviously modify your risk, but starting it even late, if you can, and these drugs are available to you to start late, will still modify risk. But of course, we should be trying to start these drugs at the earliest evidence of risk, rather than at the last minute. And then this is the subgroup which took a lot of interest because of the positive trend test and the suggestion that at low levels of albuminuria, we have smaller treatment effects on a relative scale. But you can see in the A1 levels of albuminuria in this subgroup analysis, we only had 84 outcomes. And so, whereas this analysis looks like there's no effect in people with lower albuminuria, actually the question we need to ask ourselves is there evidence of smaller effects, or is there evidence of no effect? And the way we addressed that was with eGFR slope analyses. And these eGFR slope analyses have been developed more recently and are particularly valuable for assessing subgroups where perhaps the categorical event rate is too low to assess clear effects. I'm thinking about people like people with type 1 diabetes. I'm thinking about people who've got rare glomerular diseases. And so we've been exploring this subgroup analysis in particular in recent work. And I'm going to emphasize the results of this in the rest of this talk, because a lot of this work is novel and unpublished at the moment. So just to reorientate yourself to the eGFR slope results from EMPA-KIDNEY, here is the annual rate of change in the placebo arm. So on average per year, people progressed at 2.75 mils per minute per year. There's the expected acute dip when you started empagliflozin. This is reversible, as you know, from EMPA-REG outcome, and we also see it's reversible in subsidiary analyses from EMPA-KIDNEY. And then you have this chronic slope, which slows to 1.37 mils per minute per year, and the difference between 2.75 and 1.37 is 1.37, just happens to be. So log these numbers in your memory banks, but also log this other statistic, which is if you look at the gradient of the chronic slope, and you look to see by how much it slows, that's actually around a halving. In fact, it's exactly a half. So we can turn that analysis that you've just seen into a forest plot, and you'll recognize the numbers across the bottom. You'll see the 1.37, 2.75, and 1.37, and the 50% reduction in the relative rate of decline. And I'm going to focus a lot on that relative rate of decline, and the way we calculated it was simply looking at the absolute difference in its confidence interval as a ratio of the mean rate of progression in the placebo group. And now let's look at some extended albuminuria subgroups, and this is unpublished data, but you can see that the rate of progression in the lowest albuminuria group, the A1 group, was 0.88 mils per minute per year. That's just less than 1. What some people describe as population aging, where we lose kidney function at 1 mil per minute per year. But at those with 2,000 milligrams per gram or more, they're progressing at 6 or 6 and above. So you can see there's a very wide range of patients represented in this trial. And then if you look at the effect amongst those allocated to empagliflozin, well, there was a slowing of kidney disease progression on this chronic slope in all of those groups. Of course, you can't slow people by more than 0.88 in the A1 group, so that's limited, but you can slow it by more than that in the higher albuminuria subgroups. And so if you look at this, it looks like there are different effects across the different groups, but of course there are, because there's very different absolute risks, very different absolute rates of progression. And the way, if you want to ask yourself a specific question, is does treatment work differently in people with and without albuminuria or with different levels of albuminuria, is actually to take away that difference in risk at baseline. And the way you can do that is with the relative associations of the treatment. And when you look at the relative difference across these different subgroups, then you start to see an interesting pattern. In fact, you see the opposite pattern to what we saw with the absolute differences. What we see is actually potentially a smaller effect on the chronic slope in relative terms in those with the highest levels of albuminuria, and perhaps the largest effect in those lowest levels of albuminuria. A problem with these analyses is that when you progress slowly, in actual fact, you have imprecision around the estimates, so you can see the confidence intervals are very wide. But this is telling us something, which is perhaps those analyses of the categorical outcomes, which were grossly underpowered, might be missing a key effect on kidney disease progression amongst people with lower levels of albuminuria. And so my conclusion from these analyses is that SGLT2 inhibitors slow the chronic rate of progression, and I actually counsel my patients to keep this simple. I say to them about halve the rate at which their kidneys are declining, and I think that's a very easy statistic to communicate for patients, and I think that is borne out by this data. Now, a lot of you will know about the debate between total and chronic slope. Chronic slope is my preference because of the longer-term perspective it will provide you with. We treat these patients for many more than 2 years, and of course the acute decline is reversible. But here are exactly the same analyses looking at the total slope. So this is slope for randomization to final follow-up rather than from the point after the acute dip. And you can see there's a 26% reduction in the risk in relative terms on total slope. And you can see all the dots line up above that, and the test for heterogeneity again is non-significant. So I'm hoping that this analysis brings forward some of the debate about albuminuria and gives you a better idea of some of the nuances behind the discussions that there are. But these chronic slope analyses actually provide us with an excellent way to also investigate other questions. And here are some of the other questions, and this symposium is about diabetes, so I thought I ought to show some diabetes analyses as well. And here are the results amongst those with different types of diabetes as well as those without diabetes. Now, conveniently in this case, the actual rate of progression in the placebo arm is actually very similar across the groups. This is just perhaps somewhat by chance. Those with diabetes had slightly lower levels of albuminuria than those without, and it just happens to be the average rate of progression is about 2.75 across all of these groups. So we don't have to bother with the relative risks and the relative differences here. We can make this a little bit simpler for ourselves. But you can see here are the results. Empagliflozin or allocation to empagliflozin slowed the rate of progression. And what's really nice to see is that in people with type 1 diabetes, although the estimates are very wide, they're quite imprecise, the point estimate suggests a rather large effect. And it may be that this is pointing to the fact that these drugs are getting to the heart of the key mechanism of progression in people with type 1 diabetes. So the results from EMPA-KIDNEY, which had 68 patients with type 1 diabetes in it, suggest that SGLT2 inhibitors also slow risk of progression in this group. Now, this does come with a warning, and the warning is at the bottom of this plot. And that's that all patients with type 1 diabetes in the trial were provided with a ketone meter and special advice on how to monitor for ketones and how a DKA could be prevented or the risk reduced. So if you do start to consider SGLT2 inhibitors off-label in people with type 1 diabetes, I do so with extreme care, selected patients, and with the blessing of our diabetologists and the support of a ketone meter. So I'm going to move now to some analyses which were presented at the American Society of Nephrology Kidney Week. just at the beginning of this month. And that was looking at the chronic slopes, looking at different types of kidney disease. This symposium is about diabetic kidney disease. I'm showing you the diabetic kidney disease results. But EMPA-KIDNEY, we pre-specified 4 major groups of primary kidney disease, and those were diabetic kidney disease, split from hypertensive and renovascular, split from glomerular disease, and split for other unknown causes. And you're getting familiar with these plots, so I haven't drawn the box around it, but if you look at the placebo arm, the event rate, the mean slope is presented there, and you can see that those with glomerular disease were progressing faster than those with diabetic kidney disease, and those with hypertensive and other diseases were progressing more slowly. And actually, this is nicely represented in the albuminuria data. On average, those with glomerular disease had about 700 milligrams per gram of albuminuria, and those with diabetic kidney disease were intermediate, and it was less than 200 for those with hypertensive and other diseases. But you can see that, irrespective of that fact, empagliflozin slowed the rate of progression in these subgroups in all. The differences in rates of progression, however, means that if we want to ask the question, does treatment effect differ by different types of disease, we really have to answer that, I think, with relative differences, and here is the result. A p-value for heterogeneity, a test to ask ourselves, is there statistical difference between these different types of kidney diseases amongst the patients which are represented, is non-significant, suggesting the overall estimate of a halving, that 50% reduction in the risk of chronic slope, is the best estimate of the effect of treatment on chronic slope in people with CKD, irrespective of their primary kidney diagnosis. And I didn't show the results here, but we have been doing some analyses collaboratively with HIDO and SMART-C, looking at diabetic kidney disease and a composite outcome which is harmonized, and it shows that the effects, irrespective of the trial that was conducted, scored EMPA-KIDNEY, DAPA-CKD or credence. It looks like the effects on the categorical outcomes are similar. So if you want as an argument, I think the argument's been settled by data already, Maria. There isn't much to choose between the drugs once you have standardized on kidney disease and on the outcome. And that analysis I'm showing here in a slightly more detailed form, because as a nephrologist, I have my pet diseases, just like I'm sure many of you have your pet diseases. And this was a key question we wanted to answer at the time that we were reporting the results, was that we really wanted to delve into the detail of different types of glomerular diseases. So in that collaborative meta-analysis with SMART-C, we took the DAPA-CKD and the EMPA-KIDNEY results, and we delved into where we thought we had sufficient data into the different subtypes of glomerular disease. And we picked out IgA nephropathy, FSGS, and other causes of glomerulonephritidise. And what you can see here is that we've now got over 1,000 people with IgA nephropathy studied in these trials. So we're beginning to have perhaps enough events to start looking at categorical outcomes. And it suggests here was that there was a reduction of about half in the risk of kidney disease progression in this meta-analysis. Now, it's important to note the definition of kidney disease progression was different in this meta-analysis to EMPA-KIDNEY. It is much more similar to the DAPA-CKD result. It used a 50% decline in eGFR from randomization or the need for dialysis or transplantation. We still have less data in the other subgroups if you want to look in detail, but if you look at the overall result, in actual fact, it's relatively consistent across all of the glomerular diseases. Despite these results, and they were hidden in the supplement to this Lancet paper, but despite these results, one of the most common questions I've had over the last year is, what about the effects in IgA nephropathy? And so people have really wanted to see these analyses, which are the effects on chronic slope by the subtypes of glomerular disease. And so here, I'm taking you back to EMPA-KIDNEY data again. This is a graph which I'm sure you're getting familiar with. You can almost do the presentation of this slide yourself, but you can see those numbers, 1.37, 2.75, and 1.37 across the bottom. That's the result in all of the patients from the cohort, including people with and without glomerular disease. You can see that those with IgA nephropathy are actually progressing the fastest of the types of glomerular diseases. And actually, this group had about 900 milligrams per gram of albuminuria, and nearly 100% of them had renal biopsy confirmation of their disease. And you can see there's clear evidence of slowing of progression. With other glomerulonephritidise, only about half of them had a kidney biopsy, so many of these were presumed, and of course many of them may have had IgA nephropathy, which was undiagnosed. But unfortunately, in the FSGS group, we just have a lot of imprecision about the estimate. The size of that confidence interval demonstrates the uncertainty we have about the estimates on chronic eGFR slope. And then, of course, we can standardize this, as you're aware, to just testing the question is, does treatment work differently in people with IgA nephropathy, FSGS, or other GNs in EMPA-KIDNEY? And again, the heterogeneity test is not significant, suggesting the overall results are still the most generalizable results and most precise results, and the ones that I use to counsel my patients in clinic if they have diabetic kidney disease and if they have non-diabetic kidney diseases. These drugs seem to slow risk of chronic progression by a half. So this is the news. SGLT2 inhibitors seem to slow chronic rate of progression of kidney disease irrespective of the cause. And this should really make for rather simple guidelines for the use of SGLT2 inhibitors. And maybe it's time to start thinking about the other drugs, because we've demonstrated these drugs are both safe and efficacious. That's all I have time for with this talk. I haven't even mentioned the effects of SGLT2 inhibitors on hospitalization risk. I haven't mentioned their effect on cardiovascular risk, but we have got a paper, a bioimpedance sub-study in 660 patients coming out in JASN very shortly. I haven't mentioned the effects on health economics and the post-trial follow-up, which we really hope to present this time next year. So we're doing 2 years of extra follow-up amongst all the patients. So we'll have 2 years of treatment and 4 years of observational follow-up. I haven't mentioned the fact that we're investigating the effects on biomarkers. People are interested exactly how these drugs work, because their effects, these 50% slowing of chronic eGFR decline, are much larger than the rather modest effects we see on albuminuria, which are only around 20%. And we're also now thinking about how do we treat patients now they're on a RAS inhibitor, now they're on an SGLT2 inhibitor, and still have got residual risk. What do we do next? How do we treat these people with MRAs? Are there other drugs we want to use? And perhaps other effects of SGLT2 inhibitors that might improve the tolerability, particularly the hyperkalemia effects of these drugs. So this is for next year's talk. So the talk with 2 conclusion slides are a reminder of what we said this time last year was that we randomized, together with a collaboration, 6,609 patients with chronic kidney disease in a broad range of causes. They had low levels of kidney function, they had low levels of albuminuria, and that was different to what was being previously known. And it demonstrated that in the trial that empagliflozin in the studied population, it safely reduced the primary composite outcome, and the effects were broadly consistent in people with and without diabetes and in the eGFRs studied. And what's new? Well, what's new this year is that we've used chronic slopes to much more intensively investigate the effects of treatment, and it looks like the effects are consistent irrespective of diabetes status and irrespective of the type of diabetes, including people with type 1 diabetes. It looks to be true even at the lower levels of eGFR studied in the trial, down to 15. It looks to be true irrespective of the level of albuminuria, and we've delved really rather deep into groups of primary kidney diagnosis and even subtypes of glomerular disease. And where the data really starts to run out, even for the chronic slope analyses, is down at the rarest diseases, FSGS. And although it's not available for your trip home to read, very shortly there'll be 2 detailed reports in Lancet Diabetes and Endocrinology detailing all of these chronic slope analysis, the methodology, and all of the results. So that just leaves me to say thank you to the collaborative group for all those that randomized into this study, and thank you again to the organizers.
Okay, again, thank you very much, Will, for this night talk. We learned a lot, and now is the time for Guido. Dapagliflozin, a step further, what do we have now for chronic kidney disease? Guido does not need introduction. We, all of us, know Guido. He's from Groningen, and he's leading the majority, or both of them are leading the majority of clinical trials in chronic kidney disease. Thank you very much for being here in Mallorca and in the Spanish Society of Nephrology. We are happy to have you here, and try to defend a little bit the dapagliflozin after that.
Thank you very much, Maria, and it's my great pleasure to be here. And you asked for a fight between dapagliflozin and empagliflozin, between Will and me. Well, there is no fight, except yesterday when we did our cycling trip. And I thought we had a fight and a competition who would be first on every hill, but there was no competition because Will beat me on every single hill. So that fight was already finished yesterday, and I'm glad you were not looking at that. Then I've been asked and tasked to talk about a very difficult topic, namely personalized medicine with SGLT2 inhibitors. I'm professor of clinical trials and personalized medicine, and my family always makes a joke that they say that the university has given me the wrong title because there's not so much to personalize with SGLT2 inhibitors. As you've already heard from Will, it's a very simple drug. It works for everyone. But I will look at it and I will try to convince you that in the future there may be some personalized medicine aspects. So let's take a look at the data and what the data tells us. A couple of years ago, it was estimated that the worldwide prevalence of type 2 diabetes is around 470 million people around the world. And we estimate that in 2040, 640 million people around the world will have type 2 diabetes, which is about 10% of the worldwide population. Now, understanding that about 40% of patients will develop chronic kidney disease, we estimate that the prevalence of chronic kidney disease will also increase. And in 2017, nearly 700 people were diagnosed with chronic kidney disease. That number has nowadays increased already to 840 million people. We also know that chronic kidney disease is closely associated with cardiovascular disease. And in fact, heart failure is the first and most common cardiovascular complication of chronic kidney disease, with 64 million people in 2017 diagnosed with heart failure. Interestingly, there's a close correlation between heart failure and type 2 diabetes. 25% to 40% of patients with heart failure have type 2 diabetes, and we don't know the precise underlying pathophysiological pathways and mechanisms, but we believe that insulin resistance, low-grade inflammation plays a very important role. We also know that SGLT2 inhibitors targets all these complications, CKD, cardiovascular, kidney, and diabetes, because we have a single drug that can target the cardio-kidney diabetes complications of our patients. This was demonstrated already 7 years ago in the EMPA-KIDNEY outcome trial, a safety trial, and then further shown in Canvas, Declare, and Virtus, as you can see on the slide. But more importantly, in patients with chronic kidney disease, as we have just heard, SGLT2 inhibitors can reduce the risk of kidney complications, as demonstrated first in patients with diabetic kidney disease on the left, and then the two trials that we talk about today, DAPA-CKD and EMPA-KIDNEY in patients with and without type 2 diabetes. I remember very well the date of 18th July 2020 when we analyzed and saw the results of the DAPA-CKD trial for the first time. And the first analysis we did when we did the primary statistical analysis was to look at the effect in patients with and without type 2 diabetes, because that was really the novelty at that time. Does a drug that was originally developed for type 2 diabetes also benefit the kidney in patients without diabetes? And the answer, as demonstrated here, was a clear yes, as also shown by Will already, with significant risk reductions in the DAPA-CKD trial, both in patients with type 2 diabetes on the left, as well as in patients without type 2 diabetes. And just like we've seen from the EMPA-KIDNEY trial, also in DAPA-CKD, these benefits are consistent in patients with different types of kidney disease. In the top row, we see the forest plot and the benefits of dapagliflozin in patients with diabetic nephropathy, hypertensive CKD, glomerular nephritis, or when the type of kidney disease is other or unknown. And what you can see is that in all these different types of kidney disease, SGLT2 inhibitors favor a better outcome. For the primary outcome, when we specifically look at the renal outcome, which is the same as the primary outcome but excludes cardiovascular death, so this is a very specific kidney outcome of halving of kidney function, kidney failure. But also when we look at heart failure or all-cause mortality, on the right we see the p-values for interaction which are not statistically significant, and these p-values tells us that there is no statistical evidence to suggest that the effects of SGLT2 inhibitors vary by the type of kidney disease. We also looked at patients with IgA nephropathy, and this was the analysis that we did for the first time. So we looked at the kidney-specific outcome, halving of kidney function, kidney failure, in the 270 patients with IgA nephropathy that participated in the EMPA-KIDNEY trial. And what we see is a clear effect of dapagliflozin, a 76% relative risk reduction. And some people interpret these results as if SGLT2 inhibitors can cure IgA nephropathy with such a pronounced effect. But we have to be careful with the interpretation. These are only 270 patients. There were only 20 patients in the placebo group and only 6 patients in the dapagliflozin group that experienced this kidney-specific outcome during the 2.4 years of follow-up. So it's too premature to state that SGLT2 inhibitors can really eradicate and solve the issue of IgA nephropathy. There's a wide variation around the treatment effects, and we have just seen in our previous presentation that the effects are not 76%, still a very large effect, a 40% relative risk reduction if we combine EMPA-KIDNEY and DAPA-CKD, but we should not only look at the DAPA-CKD trial. Because when we look at the GFR slopes, and they tell us much more than the few patients that experience an event, we see here at the bottom the chronic slopes that dapagliflozin significantly reduces the slope from 4.6 to 2.2 mils per minute, but there's still progression in these patients who receive dapagliflozin. And actually, when you look at the FSGS population on the right, the benefit of dapagliflozin is the same. So also in the FSGS patients, dapagliflozin, just like empagliflozin, slows that progression. Thus, so far little to personalize, right? The drug is effective in diabetics and non-diabetics, is effective in irrespective of the cause of kidney disease, effective in IgA, FSGS. What else did we do? Over the last couple of years, we did a lot of subgroup analyses. We looked at the stage of chronic kidney disease, cardiovascular disease history, heart failure history, the use of all kinds of medications, ACE inhibitors, ARBs, MRAs, diuretics. But every time, every subgroup we evaluated, there was significant benefit with point estimates favoring dapagliflozin for every outcome that we assessed. So it's a very simple drug to use, effective in many patients. You can add it on top of ACE or ARBs, but if a patient doesn't tolerate an ACE inhibitor or ARB, you can also give it. You can give it on top of an MRA, so if the patient is using finerenone and still shows disease progression, don't worry, you can add the SGLT2 inhibitor. And even when patients are using diuretics, you can just add it. Some people say that SGLT2 inhibitors are diuretics. And I think that's true. But these are special diuretics. They do much more than the traditional diuretics we have been using in clinical practice so far. This is a well-known graph that you know from many SGLT2 inhibitors. SGLT2 inhibitors, because of their mode of action, they reduce intraglomerular pressure, cause an acute dip in GFR, which is followed by a stabilization of the long-term GFR trajectory. In DAPA-CKD, this trajectory started to cross after 1 year already. And the follow-up of the trial was on average 2.4 years, but in clinical practice you're using these drugs for much longer periods of time compared to the trial duration that we are looking at. So the benefits that you will probably observe in clinical practice will be even higher than what we observe in this graph. Some people are concerned after seeing a dip in GFR and are concerned that the risk of kidney endpoints or mortality will increase. So that's why we did this analysis. Here at the bottom on the left, we see the average change from baseline to week 2 in GFR in the dapagliflozin group, the blue line, and in the placebo group. And clearly in the dapagliflozin group, there was on average a 10% decline in GFR. The starting GFR levels were 44, so on average the GFR fell by about 4 mils per minute. But in these patients that experience a 10% and perhaps even 20% dip in GFR, there was no increase in the risk of the primary composite endpoint. In contrast, a placebo patient that experienced a 20% dip in GFR had a much higher risk, which was statistically significant. So if you were on dapagliflozin, this initial dip is not directly associated with a higher risk of the primary composite outcome, and the definition is shown here. Or when we look at the kidney-specific outcome, no increased risk where the patient experienced 20 or 25% dip in GFR compared to placebo, where we again see that increase in risk. And even when we look at end-stage kidney disease or kidney death, the clinically important endpoint, you see a flat line for dapagliflozin group. So when you have 20-25%, no increase in risk, but a clear increase in that risk in the placebo group. That initial reduction in GFR is directly correlated with the reduction in albuminuria. And that is not a surprise, because it's the same as when you are making coffee in the morning. As soon as you reduce the pressure on the coffee filter, there will be less coffee dripping through the filter. And this is what is happening in the kidney as well. As soon as you decrease the intraglomerular pressure, there's less albumin flowing through the glomerular basement membrane, and thus we see a reduction in GFR. So no surprise that patients with a higher reduction in GFR after 2 weeks also had a higher reduction in albuminuria. Now on the right, you can see that those patients with a large reduction in albuminuria after 2 weeks of treatment hardly experienced any decline in GFR during the 2.4 years follow-up. This tells us that we have to monitor albuminuria over time. After the initiation of an SGLT2 inhibitor, the change in albuminuria will probably tell us something what will happen with the kidney in the future. And thus it is important that we continue to screen and to monitor for albuminuria. Now, what does an SGLT2 inhibitor do? What makes it so unique? SGLT2 inhibitors increase the sodium chloride concentration in the distal tubule. And one of the features of this effect is that it enhances the electronegative charge in the distal tubular lumen. And that increases the potassium excretion via principal cells at the cortical collecting duct. The clinical consequence of that is that we start to excrete more potassium and we lower the serum potassium levels, and thus we lower the risk of hyperkalemia. Indeed, in the Credence trial, which was the first clinical trial that demonstrated this phenomenon in diabetic kidney disease, we saw a decrease in the risk of hyperkalemia or the initiation of potassium binders. And here we see the Kaplan-Meier curve on the right for potassium binders alone. Why is this relevant? This is new data presented at the S.E.N and just published 2 weeks ago. With an SGLT2 inhibitor, we can facilitate the use of renin-angiotensin system inhibitors. Because SGLT2 inhibitors, patients with a low GFR cannot always tolerate an ACE inhibitor or ARB, but if you have an SGLT2 inhibitor on board, you can prolong the duration a patient can tolerate the ACE inhibitor or ARB. In fact, you see here that there's fewer patients who discontinued the ACE or ARB on dapagliflozin or canagliflozin, and the most often cited reason for discontinuation of the RAS inhibitor in these trials was actually hyperkalemia. Why is this important as well? This is a beautiful study conducted by my great colleagues and collaborators from Spain, José Coriz and Chus. They studied together with me the effect of dapagliflozin and eplerenone in patients with chronic kidney disease. This was an investigator-initiated crossover study where we first assessed in 46 patients with chronic kidney disease the effect of dapagliflozin on albuminuria, and we see a 19% reduction in albuminuria after 4 weeks of treatment. And when we stop the drug, you see the albuminuria levels return to the baseline value. When we then gave these patients eplerenone, we saw a 34% reduction in albuminuria, and when we stopped the drug, the albuminuria levels returned to the baseline value. Now with the combination, 19 plus 34 is 53, we see a 53% reduction in albuminuria, and when we stop the drug, the albuminuria levels return to baseline. So the two drugs beautifully work together and cause a full additive effect. They also reduce blood pressure more when you give the combination. With the single drugs, a 4 millimeter mercury blood pressure reduction, with the combination 10. But most importantly, if we look at serum potassium, increase of 0.4 with eplerenone, and then with the combination, we see a decrease. So perhaps SGLT2 inhibitors can tolerate and can reduce the hyperkalemia with an MRA. And that's why the confidence study, which is a phase 2 multinational randomized placebo-controlled trial, is currently ongoing. And that trial will assess the effect of finerenone plus empagliflozin versus finerenone versus empagliflozin alone to test this hypothesis in a much larger study of around 700 people with diabetic kidney disease. We also have heard a lot last week as well at the American Society of Nephrology about the endothelin receptor antagonist, and I'm sure that some of you in the audience have participated in this clinical trial, SONAR, which tested the effect of the selective endothelin receptor antagonist atrasentan in patients with diabetic kidney disease. And the trial demonstrated, as shown on the left, that atrasentan reduces the risk of kidney outcomes, but it has a problem. It causes fluid retention, and that can lead, in some patients, to heart failure, as shown on the right. There were more patients in the atrasentan group who experienced a hospital admission for heart failure. Could it be that SGLT2 inhibitors, because of their diuretic effects, can mitigate that fluid retention induced by an endothelin receptor antagonist? This is a very small sub-study from the SONAR trial, where 14 patients, totally against the protocol, started atrasentan at the same time when they started an SGLT2 inhibitor. That was not allowed, but in hindsight, gave us the opportunity to assess the combination versus atrasentan alone. And what we see here is that that combination reduces body weight, but not with atrasentan alone, suggesting body weight being a proxy for fluid retention, suggesting that with the combination, you might reduce the fluid retention induced by an endothelin receptor antagonist. And, shown on the right, with the combination, we see more albuminuria reduction than with atrasentan alone. These findings triggered the ZENITH study, which is a prospective clinical trial to assess another endothelin receptor antagonist, zibotentan, at very low doses, 1.5 and 2.5, in combination with dapagliflozin or dapagliflozin alone. And these data were presented last week at the American Society of Nephrology and published now in The Lancet. And the results indeed demonstrate that with the combination, after 12 weeks of treatment, we see a 50% reduction in albuminuria compared to 28% reduction with dapagliflozin alone. And these effects are completely reversible when we stop the drugs. More importantly, one of the strengths of this study was that we measured extracellular volume with bioimpedance spectroscopy. And what you see here is that with a high dose of zibotentan, 1.5, increase in total body water, but not with the low dose and not with dapagliflozin alone, a reduction. So it seems that dapagliflozin can mitigate that increase in fluid retention that you observe with an endothelin receptor antagonist, and the same patterns are seen for extracellular and intracellular volume. So in this prospective study, we demonstrate that the combination reduces albuminuria more, and we can mitigate some of the adverse events of an endothelin receptor antagonist. And then finally, only 2 days ago, we saw new data from the SELECT trial, which is a clinical trial in obese individuals, and that trial tested the effects of semaglutide. And it demonstrated that semaglutide in people with overweight or obesity reduced the risk of a cardiovascular endpoint, but look at the bottom. Nephropathy was reduced by 22%, and the kidney endpoint is defined as kidney failure, 50% GFR decline, or high albuminuria. We haven't seen the detailed analyses of the SELECT study, but again, in collaboration with my great Spanish colleagues, Maria Soler, José Coriz, and all their local colleagues, we conduct the first dedicated kidney surrogate outcome study with semaglutide to test this drug in IgA nephropathy, hypertensive CKD, or obesity-related chronic kidney disease. This is also an investigator-initiated study, and I expect that we are able to present the results of this trial next year at the Spanish Society of Nephrology with great prospect. So now with all these new drugs, beyond SGLT2 inhibitors, can we start to personalize treatment? And now I'm coming to the topic of my talk. I think the answer is yes, because we can indeed think about an obese individual with kidney disease, and maybe that individual needs an SGLT2 plus a GLP-1. A patient with heart failure, we probably want to treat with the MRA and SGLT2 inhibitor, but MRAs can cause hyperkalemia. So a patient with hyperkalemia and a very poor kidney function, maybe we can give that patient an SGLT2 inhibitor plus an endothelin receptor antagonist. And this is my simple, clinically readily available algorithm that doesn't require sexy and expensive biomarkers, but just simple brains and clinical characteristics to tailor medication for the future. I thank you very much for your attention.
Thank you very much for these fantastic talks, both Will and Guido. First of all, I would like to recognize the work of José Luis Gorriz to achieve the possibility to stay here, both Guido and Will. Please, José Luis, move to the micro. You have the privilege to open the discussion.
Juan and all of you, because we are flattered to be here with you with the most relevant person in chronic kidney disease and diabetic kidney disease. And I would like to start with a question. I suppose there will be a lot of questions of the audience. And first of all, to Guido and Will, what scenario do you foresee for in the near future of the nephroprotection? You have shown a lot of new data. This is my first question. GLP-1 receptor flow early stopped, all the evidence, all the new data. We are in a honeymoon in the clinical trial for chronic kidney disease after 20 years with a desert of any single study. What scenario do you foresee, please, Will and Guido?
I think this is such an exciting time, and those who attended the American Society of Nephrology, you felt the positive vibe everywhere. Everyone is enthusiastic. And we have to be mindful and really think about how are we going, first of all, to implement all these new findings, because we can talk about it here, but are all the patients that are seen in our clinical practice really receiving the optimal medication? I know, Jose, that you're doing a fantastic project trying to identify hidden chronic kidney disease. That's the first step. We have to screen for it, we have to find the patients, and then we have to prescribe the right medication. And then thinking about the right medication, which patient receives what medication, that is going to be the future. I don't think we should directly follow the cardiologist and bluntly start all these drugs together in 3 weeks in every patient. It will lead to a huge pill count. It will have tremendous acute effects if you start combining an MRA with an SGLT2 and directly with an ERA. The GFR may dip 10 to 50 mils per minute. But I think we have to think about the right combination, reflecting my last slide. Will.
I can't add much more to what Guido has said, but I think the reason I started doing trials was because cardiology seemed to be showing the world how you can identify large numbers of treatments. And I started to work in trials for that reason, dedicated all my time to it. So I moved from my nephrology service to full-time trialists over a decade ago. And now things are blossoming, and we've got large numbers of effective treatments. But I think we've still got a large population of people with chronic kidney disease. Hiddo described the numbers on his first slide. And I think for those investigators that are not yet used to randomizing large numbers of people into trials and haven't set up their service to have patients volunteer and be recruited at scale, need to think about how they can integrate that into their practice. Hiddo and I will think about how we design trials, which are easy for investigators to do. But I think we need to just make sure that this honeymoon doesn't come to an abrupt end, and that we have celebrations each year with even larger and even more impressive trials.
Thank you.
Questions from the audience?
If there is no question, may I have a one? There is a gap between the huge evidence and the clinical practice. You have convinced all the nephrologists we are here that the SE2 inhibitor with EMPA-KIDNEY is beneficial even in patients regarding the degree of albuminuria. It's not so clear among all doctors in Spain. Sometimes we try to transmit the GPs the evidence that we have very clear evidence. So how we do transmit, how do we convince the other colleagues to use SGLT2 inhibitors in those patients with low GFR but without albuminuria? Because there is some mechanism, my first question, what mechanism does it suggest for the benefit of this patient? And the second, how to convince other doctors, non-nephrologist doctors, to use this beneficial drug to avoid the gap between the evidence and the clinical practice?
Yes, that's great. So that's my next 20-minute talk. I think that there is one key bit of data which I think is really important, which is these drugs are not free. And they do involve some involvement in physicians, et cetera, to get them prescribed. So what we need is cost-effective analyses to demonstrate to payers the benefits of these drugs. And when I say about the benefits of these drugs, I want to, although I did spend 20 minutes talking about eGFR slopes, I think we need to think well beyond the benefits on kidney disease progression. The patients in EMPA-KIDNEY had on average an eGFR of 37. If I had an eGFR of 30 and I was progressing even at 1 ml per minute per year, I'd be desperate to try and halve that. But I also would be desperate to try and prevent development of heart failure or going to hospital with heart failure. I'd be desperate to have my weight reduced, my blood pressure reduced, reduce my edema, reduce my risk of gout, reduce the risk of hospitalization by about 40%, and potentially other things like reducing the risk of MI by about 10%. So it's very difficult to argue that we shouldn't be treating these patients who we know are at high risk and have become progressively higher risk over time. I just wish the drugs were free and easy to get hold of.
Okay. Last question, I will move. I leave.
The last one.
Go ahead.
Hiddo, what question? You were talking about the combination, different new clinical trials, but I know you're working in personalized medicine, that is the title of the talk. But the patients have a different response to different treatment. The guidelines say to prescribe SGLT2 inhibitor, S inhibitor, and so on, so on. So, but the patient has a different response to different drugs. What's the near future, and how do we respond to this situation of different answer for the different patients to the new drugs? Because some patients have a dip after SGLT2 inhibitors, some patients have high degree of decreasing albuminuria, and other patients don't decrease albuminuria. What do you think was the place of the personalized medicine from bench to bench side to apply in the clinical practice?
Yeah. First of all, I think we have to carefully think about the measurements we do in an individual patient. If we see a patient in front of us with a change in albuminuria, let's say 30%, are we then fully confident that the change in albuminuria was truly 30%? Or was it maybe 15%, but did we make a measurement error? Because we know that albuminuria fluctuates from day to day. At a population level, we see a very nice correlation between albuminuria change and clinical outcomes. And that is because we look at large population and we mitigate that day-to-day variation that we observe in an individual patient. And thus, this is something that we always have to keep in mind when we start looking at individual patients and try to interpret results for individual patients. One way to overcome this is to start and to collect more urine samples over time and take the average. But that may be cumbersome. Well, maybe we can overcome that in the future by simple home measurements so that the patient can monitor frequently the albuminuria changes him or herself. That is one thing. The other thing, I think, is that we should follow the guidelines. The American Diabetes Guideline recommends to add additional medication if the albuminuria stays high. And I think we have to consider that. Suppose you have a patient with an albuminuria of 1,000 that starts an SGLT2 inhibitor, and suppose that it reduces to 600 consistently. That patient has the same risk as a placebo-treated patient with an albuminuria level of 600. So you have reduced that risk already, but still there's a high residual risk. And in those patients, we have to think about additional medications like MRAs, and in the future GLP-1s or endothelin receptor antagonists.
Thank you for allowing me 3 questions.
Okay, more questions? Secundino.
Oh, William Guido, very nice presentation, so it's a pleasure to hear you here in Palma de Mallorca, as in S.E.N either. So the question is that we have more, not only for the focus on the kidney, if there is another tissue who are improvement or have improved with the drugs, especially naive LAD, so fatty liver disease is also another entity to be a focus on, in the sense of that diabetic and obesity and another pathology like focal glomerulosclerosis or IgA has involving the liver. So what is your opinion, both of you, what is your opinion about these secondary beneficial effects in other tissues? Thanks.
Yeah.
Well, we have spent nearly an hour here and we haven't mentioned acute kidney injury. So I'm fascinated by the tubules and the acute kidney injury. I'm going to bring it back to kidneys because in actual fact that might tell us a lot about how these drugs are working. We've always thought it might be intraglomerular hypertension. We've talked a lot about albuminuria, but these drugs are working in people with low levels of albuminuria and we need to understand why. I'm sure there are a whole series of other things which we will learn about these drugs. And the way that I'm approaching it, and I know others are thinking of the same, is to use the urine and use the blood to look at the proteins and the lipids, the metabolome, the proteome, and to assess all the effects of these drugs, because we're clearly finding that they're a treatment for many more things than we originally targeted them for.
Secondly, first of all, I would like to thank you also for being such a good collaborator in the investigator-initiated trials. You have been contributing a lot to the GLP-1 trials. Now, coming to the GLP-1 trials, I think that these drugs also have an effect on the liver, as you say, and we recognize more and more that type 2 diabetes, chronic kidney disease, are general conditions, obesity associated with 200 diseases, and the different organs, they interact. So if there's damage to one organ, it's no surprise that there is damage to another organ. And I would think that with GLP-1 receptor agonists that have such a profound effect on lowering fat mass, and fat mass in the liver can cause liver disease. So I wouldn't be surprised that these drugs would also have beneficial effects. I don't know about SGLT2 inhibitors, perhaps a little bit, but the future is, I think, the incretins.
So thank you so much, both of you.
Okay, there are more questions, but we have on time, and in order to respect the next session, we have to finish here. Thank you so much for staying here.
Thank you very much. I think that they are not fighting together. I realize that we are all fighting against kidney disease.
That's all right, yes.
Yeah.